through your experience, and just have an open platform to discuss all the achievements and challenges around the model of care. I hope that you're all engaged in the model of care program at your clusters, or are engaged with the teams. Or this is opportunity to also reach out and to teams on the ground and learn more about the great work that's been going on. So I'm gonna start with an overview of the model of care. Or after that we have so the overview will give you just the history of the program and how it was developed and where we're at today. And then Miss Jessica from E1 will introduce us to the role of nursing in model of care and the extensive experience she's had in the past few years with E1 implementing great services and pathways on the ground. And then Miss Jinan will also deep dive into the important role of nursing in primary health care, as well as the recent kind of services and great change that has and progress that has happened on the ground. So to start my presentation, I think it deserves to start with some stories of how the model of care has impacted the work and the patient directly, and where we're at today. And the best person to give some of a flavor of this change is Dr. Mariam Al-Qasir, who is an MOC lead in E1 and director of the model of care in the Eastern regional hub. And if these terms are new to you, the regional hub and center of excellence, I'll be explaining that along the presentation. So I'll hand it over to Dr. Mariam to give us some of these achievements that they've experienced so far.
Hello?
Hello, Doctora. Yes, we hear you. You're on mute now.
Yes, can you hear me?
Yes, perfect. We hear you. Thank you.
So just thank you
دكتورة
very much
صوتك
for the
شوي
invite.
بعيد، ده تقربين شوي للمايك.
تسمعوني الحين؟
ايوه تمام كذا.
Okay, thank you very much for the invite. I can't reiterate how important is the role of nursing in everything in the healthcare industry. You are the spine and the backbone of the healthcare industry, so thank you very much for your work. And more importantly, if we're going to fix whatever we need to fix through the new model of care, well, nursing are the front runners that with their help will be able to implement it. And this was easily and very clearly demonstrated in E1 when we held shook hands with the nursing. We saw a tremendous way going forward. So I'm just going to showcase maybe one or two stories, and these are true stories that where nursing really beautifully demonstrated their help with us. So the first one is a story about the urgent care centers, and this is a story that it's about a year old at this stage. September of last year, Mohammed was a 55-year-old gentleman who went to the emergency department with lower back pain. Mohammed was triaged by the nursing area in one of the hospitals in E1, and he was told that he has one of two options. The first option was to stay in and to be seen in the emergency, but because Mohammed was CTAS 5, he would have to wait about 4 to 5 hours because they have a higher acuity cases. And the second option was that Mohammed could go to the urgent care center, which is about 5 to 10 minutes drive, and he will be seen quicker within half an hour. Mohammed opted to go to the urgent care center, and this was his experience. And he had messaged, funnily enough, one of the nurses over there to explain his experience. This was a message sent by his cousin. So it says قبل قليل أخذت أحد أقربائي وكان يشتكي من ألم في أسفل الظهر إلى مركز صحي الجيش. دخلنا على الطبيبة بسرعة وكان تعامل رائع من فريق التمريض ومن الطبيبة، والأهم السرعة في الحصول على الخدمة العلاجية المناسبة. شكرا لكل من ساهم في الوصول إلى هذه النتيجة المفيدة. This beautifully again illustrates that For those who are non-Arabic speaking, I apologize. It basically just says that he had taken his cousin over to the urgent care center. They entered very quickly. There was beautiful treatment by the nursing staff and by the physician, and they got the appropriate care in a timely manner. So this again beautifully demonstrates how the important role of nursing, from the point of triage to triage away to access to care and everything there going forward. And this was again a success based on nursing, really more so than anybody else. And again, I am a physician, but I think I was in nursing in a previous life. If I go to the next slide, if you don't mind, Noura, and then I will maybe, if we have Noura's.
I'm
So this is
controlling the slide, Dr. Mariam. Just let me
okay.
know.
تفضلي حياتي.
Yes.
So they go to the next slide. And again, the urgent, this story, yes, Noura's story. So Noura is actually a physician who was a board certified family physician who was working out of Dammam. She had taken an interest in model of care. And what we told her to do is we told her, because she knows the area, to really manage the care coordinators over there. So she was working hand in hand with all of the nurses that are managing the care coordination in Dammam. Um, with um, with the curfews, people were quarantined during COVID, and the model of care initiatives very quickly started to reroute their priorities to address urgent care centers and keep well along with telemedicine arms. We totally forgot um, about chronic care patients. Not totally forgot, but we deprioritized them. We received a message from Noura, Dr. Noura, in the mid of April, like basically 6 weeks after the curfew. And basically what she said is that the care coordinators took it upon themselves. These are nurses. They took it upon themselves to work from home and contact all of their patients that they're responsible for, to make sure that they're well, the chronic patients are well, and they're looked after, and that their medications are adequately refilled through Wasfati, so they're capable to get their medications in their nearest dawa pharmacy next to their homes. So in 6 weeks' time, they were able to contact 4,799 chronic patients from Dammam and look after them. The beauty of this story is not that they've actually done their work. The beauty of this story is that even without instruction or supervision, the on-site team were able to become very proactive, very creative in managing it, and they felt empowered, accountable, and very patient-centered. So they, even without anybody telling them, oh, don't forget to look after their patients, they did that themselves, even during a time where they were quarantined. Some of them were, curfewed. They weren't able to get to the primary health care, yet they were able to make sure that their patients are well managed, and and their medications are catered for. So these are just a couple of success stories that came in, and very much driven by nursing. So thank you very much for your help with us in terms of implementing the model of care. Thanks a lot. Back to you, Noura.
Thank you very much, Dr. Mariam. These stories always help to kind of realize the impact that is happening on the ground. I see with us Dr. Mohammed Saghir. I don't know if you would like to say a few words. Okay. So one of the aims, as Dr. Mariam mentioned, Het, if you can go to the next slide. So a lot of what were kind of the direction and the principles that we're following in the healthcare transformation as a whole are centered around the triple aim. which is the IHI, the Institute for Healthcare Improvements framework, to introduce and instill value in care. So focusing on improving population health, improving patient experience, and lowering costs per capita. And some call it the fourth quadruple aim, which is joy at work. And these principles are the drivers and the North Star for our design and implementation of any initiative within the transformation, keeping in mind the 6 aims to improve healthcare quality as well. And when we started, in the next slide, designing the model of care in late 2016, we were inspired by these principles to set national guidance and direction to design our future state of healthcare services. And these principles were based on empowering individuals and their family to take control of their health, to keep individuals healthy, focusing on prevention rather than on treatment, integrating all layers of care, keeping in line with the whole clustering approach, making knowledge and information available to patients and caregivers, and providing the best value of care. And so the overarching design objective was to create a system, create services that are centered around the population needs. In the next slide, we then give a brief, want to introduce you to a brief history of where the model of care started. So as I mentioned, in the end of 2016, we scanned the world healthcare systems to learn from these experiences. We looked at global trends in healthcare, whether it's around accountable care organizations or population health management and so. And we looked at local institutions and other sectors who were successfully implementing their own models of care. And from that came the model of care design. Now, the model of care design is also based on certain initiatives that support the implementation of this framework. In the next slide, I'll detail the flower, as we like to call it. So the model of care, as I mentioned, has an overarching principle to design services and pathways based on population needs. So we looked at population needs from the beginning of life till
نورة السلام عليكم.
وعليكم
عذرا
السلام
عن
ورحمة الله.
المقاطعة.
لا
نورة
أبدا
and
بالعكس.
Mariam and the team. Sorry, I was having a problem with my microphone.
Oh.
I was في البداية I was talking but I did not.
ما كنت
was
نسمعك
not able to
دكتور
reach.
أشوفك yes sorry.
Yeah, I was trying to do it so then I'm talking to you. There is some problem in my. I think it's in the computer.
No worries.
So we have all the chief nursing officers from all the clusters.
Yes.
Yes.
And just if you allow me, can I give some
Please.
introduction? Is
Yes,
that possible?
Sure, of course.
Is Mariam and the other hub leaders there, or just Mariam?
موجودين.
الله يعطيك العافية. No, thank you so much for arranging this and arranging this connect. I think this is, I would say, in all of the connect sessions we have, this is the most important connect session we have. The nurses is definitely the engine, and they are very critical in this process. They are the most important. This transformation will empower and enable the nurses much more. It's in fact, all of it is about empowering patients and empowering frontliners and empowering nursing staff and increasing the role of nursing in the multidisciplinary teams that are going to be developed. You will see from the model that the nursing in the primary care, they will be far much more empowered to do the work. Our business is going to be in the primary care and in the community services. There is going to be a significant empowerment to do this. Also, upskilling staff to support nurses in the multidisciplinary team, either support finding a nursing coordinator jobs, but also finding a nursing support like a nurse's assistant or other staff to support the nurses, the psychologists, the social workers, the allied health, the pharmacist, the physician assistant, the nursing assistant. So all of these are new jobs that are going to be developed to help the nurses to empower them to do their jobs. We are here at the Health Holding Company, we see the nurses as an essential partners of this process, and we see them are very important. We look forward for your ideas. Please share them with them. Speak to us through the chat. Speak to all of the hub leads. Demand our services, please. We ask you, please pull us down. We are happy to visit your departments. We are happy to visit your institutions. We are happy to attend your activities, your clubs. We are happy to share any documents that you want. We need your help in making this transformation happen for the kingdom. We need to leapfrog badly to the future. The sustainability that will have in the system is not only in the type of clinical service we provide, but also in the financial services that become compatible and supportive and enabling. There is more enablers to come in the future, but this is basically in the summary what I wanted to say to you. And I want to thank you for giving us the time and the opportunity to speak to you. And happy anytime to get in touch with you and to work with you. So these are my thoughts and ideas. I don't know, Mariam and the team, if you want anything else from me, or if there is any question from the audience. All our chief officers, nursing officers, I'm happy to hear and listen. Or if you can pass it to the team, I'm also happy to receive them. Thank you so much.
Thank you, Dr. Mohammed. يعطيك العافية. Do you have any question for Dr. Mohammed before he's leaving? Are you going to stay with us, Dr. معنا the whole meetings? Are you going to stay?
And initially, I will say for the early minutes, but then if you guys excuse, allow me, I might need to leave at 1:35, if that's okay with everyone.
Thank you, Dr. Mohammed. If you have any question, please, can you type it in the chat, and then we're going to discuss it with Dr. Mohammed later within the time. Thank you.
Happy to do that.
Thank you, Dr.
Thank you so much.
Thank you. Nora, if you want to continue your presentation, please.
Absolutely. Thank you, Dr. Mohammed. And yes, so to reiterate the messages that came from Dr. Mohammed and Dr. Mariam, the model of care is designed based on population needs and has been mapping any individual needs from beginning of life to the end of life. And that's where the 6 systems of care were ultimately created. And within each system of care, the services are delivered within the 6 layers of a service. And these layers are integrated and based on collaboration and shared resourcing. So to achieve these objectives, in the next slide, we outline the 42 initiatives under the model of care that allow us to realize the outcomes that we have put forward for the model of care. Each system of care sets below it or within it services and initiatives that together form a patient pathway or an individual pathway. And within these services, obviously, there are certain workforce needs, upskilling of workforce, operational manuals, resourcing that needs to be provided. And within a majority of these services and initiatives require nursing to be at the forefront that can deliver these services and can have more responsibility and autonomy in serving their patients. At the cross-cutting level, which is still at the slide at the row above, is the cross-cutting initiatives or interventions that you might have heard about before. And these interventions are mostly within the digital realm, research or data related.
Noura, if I
yes.
suggest something also,
Please.
I think the information that you guys are going to receive today, they are extensive. It's a lot.
Yes.
It's a lot of information, this blueprint, this work being done by the team over the last 4 years. So please do not shy away from asking for one-to-one meeting and deep dive with the team at your convenience. And the team at the hub is very prepared and willing to do that. I speak in their behalf, but this is something definitely we can be happy to share with you.
Absolutely. Thank you, Dr. Mohammed. Yes, and we will be sharing the material and the model of care report that was produced after this piece of work that details all the services and all interventions for your review, and open to have further discussions on those. And so the cross-cutting initiatives on the top row relate to interventions that will support and enable the implementation of the systems of care. One of the most important ones is enhancing primary care, which is improving and supporting the enhancement of primary healthcare centers to deliver all these pathways and services within the 6 systems of care. And we'll be talking about that in future meetings and deep diving into those priority initiatives as we go. In the next slide. So, and that's from a design perspective, how the model of care was initiated. After the design was finalized in mid-2017, the minister, His Excellency the Minister, had launched the model of care. We had a public announcement around the new model of care to be delivered in Saudi. And after that was a milestone to begin in the implementation of these pathways. So as clusters were beginning to be established, each cluster adopted or took a pathway to design and detail it further, and develop pathway manuals that I hope you all have access to, and then piloting some of these initiatives and pathways on the ground to collect the lessons learned, which Jessica will speak more about. And now we are in the national rollout, where each cluster is scaling up these pathways and has developed their 2-year plan. So in the next slide, it illustrates how we took a phased approach in rolling out the model of care, starting with building the teams, building the leadership that will drive the work forward, and building the capabilities of the implementation teams on the ground to scale up and roll out certain initiatives as they go. So each cluster has a 2-year plan that details the initiatives and pathways that they will implement in the next 2 years, keeping in mind with all the principles that I mentioned earlier on of integration and accessibility of care. And I urge you all to if you do not have already kind of a visibility on those plans, these plans are the blueprint that each cluster is following to achieve the objectives that they have set forward. And to, in the next slide, to give you kind of a flavor of the journey that the model of care kind of takes, it's not a change that will happen day and night. It takes a lot of change effort and leadership drive and championing on the ground. And so to do that, we start with setting up the model of care teams. And I know today we have some unclustered regions. So we have some of the regions that still are establishing their teams. So you start with establishing your model of care team, starting with the PMO office, the leadership on the ground, identifying the change agents and the champion, and then piloting a certain pathway or initiative, which the whole country now has implemented, the hypertension pathway, and is in the process of scaling that up. As you scale up, each cluster develops their 2-year plan, which requires the approval of the chairman and the CEO. And as they go, they begin implementation, and that's where really the lessons learned and the operational excellence is translated as they move forward with their ACO journey, which is something we will introduce in future sessions as well. So in the next slide, just to give you also some insight of some of the achievements that clusters have achieved so far. There has been significant facility collaboration. So primary healthcare centers and hospitals are better integrated, better connected, have better communication channels, which is in line with our aims. Patient satisfaction has increased, especially at primary healthcare level. Services are more available, and Dr. Mariam has exemplified some of these stories. Leadership has become decentralized due to these plans being owned by the cluster and being designed by the cluster. They have the autonomy to see what fits best to their population, their resources, and where they require to improve. Pathways are now designed and formalized based on these principles of integration and accessibility. Care is not seen in silo as before. And there's hopefully more awareness created around the importance of designing services around individual needs, and more awareness with the let's say consumer or the patient or the individual, that they have to be an active participant in their care. And these are some of the kind of numbers that also illustrate that we have been enrolling more patients into these services. There's been higher impact as we go. To the next slide. Let's skip this one. And so linking it back to the triple aim, what we, and this is a work in progress, as I said, it's a journey, as we prioritize pathways. So pathways within the 2-year plan are also prioritized based on the prevalence of disease and the demand on the ground. And so pathways are prioritized, which results in meeting population needs, addressing patient experience. We're mobilizing resources across facilities and moving resources where the demand sits. And this is hopefully reducing the waste and increasing efficiency. And there's a lot of training for physicians and nursing and allied health professionals within the new model of care roles. And this is a session as well that will dedicate a few kind of sessions forward, where we'll talk about the new model of care roles, which ones relate to nursing, what kind of training will be delivered, and your support in this will be key. And all of this just to kind of give you some kind of clarity around the direction we are heading, is to support as a health holding company with its 5 regional hubs are aimed to support the clusters in moving forward in their model of care implementation journey, to support you in piloting initiatives, scaling them up, and achieving your rollout plan objectives. And in the next slide, this is achieved through this structure. In the next slide, please. We have the Model of Care Center of Excellence at the central level or at the national level that will define the standards and guidelines and national direction for the model of care, which will be delivered through support in the regional hubs. So there are 5 regional hubs. The West led by Dr. Osama Al-Wafi, the East led by Dr. Mariam Al-Qasir, the Central led by Dr. Yusuf Al-Amran, the North led by Dr. Sami Shimmeri, and the South led by Dr. Ibrahim bin Hussein. They are there to support in any needs you have to better be equipped and enabled to implement these services on the ground. So we are gonna definitely set up one-to-one meetings with the hubs, and as Dr. Mohammed mentioned, support you in any way we can to enable you to implement this work moving forward. So that is kind of an overview of the work. If you have any questions, any comments, if you want to introduce yourself, maybe give a brief of the work you've done. If any of this is new to you or you have implemented some of this, please feel free to unmute yourself, and we would love to hear from you.
Thank you, Nora, for your presentation. Please raise your hand or type your question or your comments in the chat so we'll be able to read it. Thank you.
Okay, so Hayat, if no one has any
Yes.
comments or questions, maybe we'll move to Miss Jessica.
So this
Thank you
next,
everyone for
yeah.
your time.
Thank you, Nora. Thank you. It's a time for Jessica now to present the role of nursing in model of care and give her experience in E1. So Jessica, please. Jessica. Jessica, can you hear us?
Oh, sorry. Can you hear
Yeah.
me now?
Yes.
Good afternoon, everyone. Thank you for organizing this. And thanks to the organizing committee for having me. Hello?
Yes, Jessica, can you raise your voice, please?
Yeah,
Little
can you
bit.
get closer to the mic, please? Yeah.
Is this better? Hello? Is this better?
Yes, a
Can you hear?
bit. You can
Yes.
still go a bit louder if you can.
Oh dear. I'm right in the phone. So good afternoon, everyone. Thank you for the organizing committee for having me. It's my pleasure to share our experience in E1. It's been a long journey, almost 3 years now. While I talk about our experience, what I want the chief nurses of each region to do is to sit back and think about your role as you lead your teams, from the frontline staff to the leadership teams and their teams. I know a lot of y'all are at different places in the journey with the model of care. Some of y'all started with us, some of y'all probably started midway, and some are beginning. So forgive me if I'm talking and you don't understand what I'm saying, but I'll be glad to discuss it offline or share some of the terminology that we may use here in the E1 when it comes to sectors or zones or integrated health. So you may hear some terminology that you're not familiar with, but we'll be glad to explain that later. So leaders, be engaged. Think about how you're going to get your teams involved and lead your teams. For the objectives for today, we're going to talk about a brief overview. Thanks, Noura, for the model of care overview. So I may not have to spend a lot of time on that, but talk about the lessons learned from the E1 model of care pilot for the chronic disease pathway, the role of the nurse in care coordination and the multidisciplinary team through the continuum of care, and then again, the nurse leader's role in the infrastructure that you create for the integrated healthcare network to support the model of care. So the next slide, please. So the healthcare transformation in E1 has three interdependent goals. The main goal is to improve the patient care experience, to improve the health of our population, and to reduce the cost per capita in expenses. Next. So the model of care, as Noura elegantly explained, is based on 6 systems of care. The centers around ensuring patient that centers around ensuring patient well-being and contributing to healthier society. For the purpose of this discussion, I will focus on the chronic disease pathway that we were involved initially. Next slide. So I'm not going to go into the details of the whole model of care when it started, but I will talk a little about the pilot. And I think here the success for the pilot for us in the Eastern Province was mainly making sure that we were very selective in what we were doing, the people that were involved, and then making sure that we had subject matter experts to support us with the chronic disease pathway. So the teams and the team responsibility, as you see on the slide, were for the pilot leadership, for the chronic care pilot leadership and coordination team, their role was to approve the decisions and set timelines. They also provided a connection with other programs, initiatives, and stakeholders outside the program. For the design team, their main responsibility was to prepare strategies for the pilot, detail the operationalized pathways, and develop gap resolutions. And then for the implementation teams, the main role for them was to make sure that they operationalize the decisions that were made on the ground, monitor the process, and also report to the process to the facilities, but then troubleshoot any issues that came up at the facility. So when we say monitoring, we needed to make sure that we had quality reps that were monitoring the whole pathway that was tested and then finally put into commission. Next. So I'm particularly proud of this slide as we worked hard on making sure that the patient's journey was clear to both not only the patient, not only the providers, but also to the patients. As you can see in this slide, we really took time to make sure that we connected with the patient's journey for where the patient begins to keep the patient healthy in their communities with early screening and detection of and diagnosis. Once a diagnosis was made, it was very crucial to make sure that these patients were connected in their primary healthcare center. If they had a physician, that was straightforward. If they didn't have a physician, then making sure that every patient was registered and knew which primary healthcare center they needed to go. Because I think at that point, we were trying to maintain patients in their communities and also closer to their physicians. However, we did not emphasize whether the patient could go out of their jurisdiction at that point. And then once a patient has a diagnosis, the goal of the primary healthcare team was mainly to keep that patient healthy in the PHC and then appropriately refer the patient to secondary or to the secondary hospital or to the secondary clinic based on the patient's diagnosis. Now, as you can see, the little blue nurse there was the chronic disease nurse who was coordinating care from the primary healthcare clinic to the secondary and back, and if needed, from the secondary clinic up to the tertiary center, depending on a referral system, and then back to either the PHC or the patient goes home. Next. As we said, model of care is the central part of the transformation. And for the model of care to be successful, there has to be a governance structure, corporatization support arm, definitely training, having adequate workforce, and then e-health and EMR so that we could make sure that every part of the pathway was documented and communicated between the facilities. The redesign approach to care here, as you see for the chronic care, was basically making sure that we, for the purpose of this presentation, I'm going to talk about the hypertension pathway, but basically meeting with the key stakeholders to make sure that we were able to build a pathway that was sustainable within the E1 cluster. Next. So as I said, as we started looking at the hypertension pathway, we soon realized if we were to have 10 different pathways for all the chronic conditions that we were working on in E1, we would have 10 different pathways for the same patient who may have comorbidities. So it became very clear to us sooner than later that we needed to cluster our patients' care. And also while we create the care coordinator's role, how do we make sure that the care coordinator is knowledgeable and has the training for all the comorbidities that their patient may have? Next. So as we started thinking about the pathway, we basically, like I said initially, we had to meet with our subject matter experts and unify our thoughts and how we were going to work on the pathway. So we had physicians who were subject matter experts with a multidisciplinary team talking about the standards of care for hypertension or diabetes. And so there was a whole model of care team that actually took a lot of time to meet with people, prepared activities, had workshops, interviewed several people, did site visits, did readiness assessments, looked at the infrastructure for IT, and came up with the gaps and also the opportunities that we needed to work on. Next. So as you can see, one of the examples was the Al-Jalabia PHC that we spent a lot of time um, assessing and then rolling out our pathway, hypertension pathway. And if you look at this readiness assessment, we talked to the doctors, we looked at how many patients they have, how many hypertensive patients out of that total population, and then how were we going to manage those patients if we had a care coordinator that was going to help coordinate that care for those patients. So typically we took a reasonable number of one coordinator for every 200 patients to manage their care. And so initially it was manageable because we were right in the range of where we wanted to be. So we had one or two care coordinators in each clinic. We also had to make sure that we had adequate nurses. There were lots of nurses that were already acting in those positions, but may have not had the knowledge and skill that we were able to give them through the model of care and the training that was needed. Again, the other assessments were pharmacy, making sure that the appropriate meds, for example, in hypertension, making sure that the hypertensive medicines were available at the clinic so that the patient didn't have to leave the clinic and go to the hospital to get their medications, which was the practice. Again, looking at the labs and making sure that the labs were available locally, because once the patient leaves the clinic, typically we know we lose them, because many a times they don't go and get the testing and are not monitored closely because there's no way to monitor them. But also with our systems being working in silos, we may have a lab test done in the hospital, but the doctor in the clinic may not be able to have access to that result. And when we talk about IT and hardware, this was a big surprise for us when we first went to, I'm not sure if it was this very clinic, but when we went there and we said, how do you call patients and where's your telephone lines? We couldn't believe there were no landlines even in the clinic. So talking about looking at the infrastructure and trying to figure out how to support them, this was a big aha moment. How do you even communicate with your patients when you don't have access to a telephone? And I think with the model of care, we were very successful in building a great infrastructure to support these clinics, to get the IT, to get the phone and so forth to service the patient locally in those clinics. We also had to look at the facility because many of the facilities were older. Some of them were like we have here, low, medium, and high impact. Sometimes our chronic disease patients were coming, with obesity, heart disease, and hypertension, and then we would expect them to run a flight of steps because there was no elevator in that building. So again, trying to figure out how to redesign and support these patients. Next slide. So when you look at this slide, it basically talks about all the gaps that we had from our assessment. It was very clear that we needed, our nurses needed more education. Even the physicians, when we, most of the clinics have GPs and few family practice doctors, but it was very clear to us that these doctors were not knowledgeable of when to refer their patient to the family physicians. Some of these patients were referred inappropriately to secondary hospitals. There was no system to bring those patients back, and so they were bottlenecking in the secondary hospitals. Then when we started looking at equipment, simple equipment for blood pressure monitoring, some of the machines were not calibrated. Many of them didn't have the right cuffs. The nurses were not empowered to speak up and to ask for more equipment, shortage of staffing, medication issues. And then, like I said, there were lots of IT issues, and then there were no EMRs because everything was in silo. So definitely a lot of work to be done. And the lessons learned here were, in order to allow or to take a new pathway to any clinic, is to make sure that the readiness assessment is done, the gaps are assessed, but also have some solutions for them. The good thing with model of care is it has the infrastructure for us to voice our issues, to escalate some of the difficulties we are having in terms of getting equipment or getting the support that you need or getting the medication. I very well remember a situation in the pharmacy when we went to one of the clinics and we were trying to monitor what medications were available. And time again, the doctors and the nurses and the pharmacists will tell us that most of the medications we need for hypertension are not available. And when we went to the logistics department in the central office and asked them, what's your process and how do you dispense these medications? There was clearly a process, but obviously the little attendee there decided that because all the sick patients go to the hospital, that they were supposed to send more than 60% of the medications directly to the hospital. It was just his decision, thinking he was doing a great service to patients who needed medications in the hospital. And it was very clear to us that there was no oversight, or there was no way of monitoring what kind of patients we see in which clinic, what kind of medications we needed, and how to deploy those medications from central logistics. So soon, I think a team went back and looked at it and said, no, this is not the way we're going to do business in the future. And we need to make sure that we are dispensing medications appropriately based on the need for each clinic. So we quickly had to get our quality teams to measure this, to know exactly how many hypertensive patients were in each clinic, what kind of medications they're on, and come up with a par level where we were able to at least say, we need to have X amount of A, B, C, D medications so that they're available to our patients. So a lot of lessons learned. I remember when we first went to the nurses and talked to them about the model of care, we had a lot of nurses say to us in 2 or 3 clinics, lots of teams have come and gone, and what makes you think you're going to be different? What makes us believe that you're going to come and help us? And I think the success story was as we started to go and go more frequently. Initially, we were going once a week just to assess, talk to them, get familiar, see what was going on. But once the pathway was ready and we were ready to roll it out, it was very clear that to them that we were there to stay. We were coming, we were not pointing fingers, we were supporting them, we were looking for the gaps. We were saying, okay, we can help you with this, we can get you more computers. And as soon as the reality really hit, that they were getting telephones, computers, Wi-Fi connection, medications were coming to their clinic, we were supporting them with the training that they needed to understand the pathways. Soon they realized that we were there to stay, and it was amazing how the nurses were actually having huddles in front of the make sure that their patients and their clinic knew exactly what was going on with the model of care. Next. So here it's very clear that in order to run the model of care, we really need dedicated nurses at all levels, especially in the clinics, to coordinate this care with the multidisciplinary team. Next. So some of the main responsibilities for the care coordinators, making sure that they are being proactive with their patient care, making sure that they understand their patients that are going to come to the clinic, have proactively with the previous 24 hours to set up a plan for their patient visits, organize their charts, make sure that they contact the patient, do the patient education, follow up with their labs, make sure that if something needs to be flagged for the physician, that it's proactively done by the nurse, make appropriate referrals for secondary hospitals or for tests, and then appropriately refer their patients to the ER when needed. But also we started remote monitoring, which enabled some of the clinics to be able to see their patients' blood pressure remotely and appropriately ask them to come back to the clinic should they needed more assistance. So I won't go into the details of the main responsibilities, but that's kind of the overview of what we supported them with. Go ahead, next. So here again, the governance to coordinate the process, patient, and making sure that not only the care coordinator is in the center of this, but making sure that the care coordinator is engaging their patients, assessing them, developing a care plan, coordinating their care, and monitoring their results. So the care coordinator's role is very specific and is the proactive and the retroactive work that she does to prepare for that patient to come to the clinic so that patients time is managed in a way that the patient feels like people care, they know about me, they're prepared for me, and they're able to take care of my needs. Next. So here's a sample care coordination job description, because once we realized the role for the care coordinator was very specific, we tried to come up with the job description. Now, this was the initial job description, and hence, since we've adapted and modified this, but we'll be glad to share that should you be interested at a later point. Next. So this is the future state of a patient's journey. I think this slide basically is saying how we prepare for these patients in their journey and how we communicate between the healthcare workers, the patient, and the nurse. I won't go into those details, but as you work through the model of care in your area, you will come up with your own future journey for the patient in the PHCs. Next. So this is a slide that we put together. The reason I wanted to show standard work was because it was very apparent to us that as the model of care was progressing, there was a lot of confusion in what people were understanding of who has to do what and how this would be sustained in the clinic. So one of the things we did with the pilot was saying, let's standardize the work. Everyone in the clinic needs to know who's doing what. So the work step was very clear, who was responsible for that work step. And the key point was basically saying for that work step, what does someone have to do? So for the first work step there was generate appointment list for CMR patients to be seen in the clinic. And it was very clear here, it was the care coordinator and the receptionist's job. So what they were supposed to do was to print the appointment list by noon of the previous day, call the patient to confirm the appointment, and also in the future, we said bring their medication for med reconciliation. So the standard work was basically to emphasize, but at the same time, make sure that everyone in that team knew exactly who was supposed to be doing what for that patient, even before the patient stepped into the clinic. And once the patient stepped into the clinic, then what happens? And how do we make sure that we have a smooth transition for this patient without too many bottlenecks of looking for his chart or the doctor's not here or need to reschedule and so forth. So making sure that doctors were available, nurses knew this patient was coming, they're proactive with their care, and then closing the loop for our patients. Next. So now I think that was as far as the role of the care coordinator goes. Now I'd like to focus on a few slides that are going to help us as leaders to basically think about your role while you standardize the nurse manager, the nurse director, and your frontline staff's role in the model of care. So if you look at these design principles, the first principle basically says clinical standards are set by the cluster and disseminated to facilities. The second design principle for, we call the clinical excellence in the E1 cluster, where nursing physicians and the allied staff with quality report to one VP. So this was some of the design principles that came up from the clinical excellence. So again, the first clinical excellence design principle was creating clinical standards set by the cluster and disseminated to the facilities. The second one was the cluster plays a capability building role for less developed facilities. So one of the big aha moment for me was as we lead these teams and create structure was how are we going to build the capabilities of organizations that not at the same level as maybe more mature organization. So I think the next slide will talk about the 2-year nursing plan that we put together. And because nursing is huge and there were lots of different things that we had to do for nursing, we broke it up into nursing affairs, which is nothing else but your HR affairs, the nursing operations, and then nursing quality and education. And under each element, we tried to look at what are the big things that the cluster can do to centralize and standardize so each hospital doesn't have to reinvent the wheel. So if you look at the nursing affairs, the biggest thing that we selected there was making sure that nursing organizational charts were centralized, the scope of practice, job descriptions, and the performance appraisal planned at all levels. We also developed a recruitment plan and retention strategies for nursing needs in the cluster. For the operations, we basically tried to look at the scope of service for each subspecialty and for each hospital. And then definitely in operations, collaborating with the model of care and service line leads to meet clinical excellence goals as planned. And then the other two were quality and professional development, because most of our hospitals, the capabilities for our education department and quality existed, but they were not at the level that we expected in terms of the capability, the staffing, the education, and so forth. So I urge each and every chief nurse to actually take time to think about your model in your cluster. We are almost towards the tail end of the 2-year charter for us. So a lot of these components have been already designed, implemented, and some are embedded. There is definitely opportunity. For example, we are working on a succession plan with our leadership team. And we started this journey about a year ago, but we know we're at the crossroads where we are trying to roll out the competencies for them. But that will not end at the end of this charter. We hope to continue that into the next year, giving them a whole 2-year plan so that they can strengthen their capabilities as nurse leaders, because many of them are young, were put into those positions not through a succession plan. And so making sure we support them, strengthen them, and embed them with the tools that they need, but also through a workshop now, we're trying to say, let's fill the gaps, let's support you, and make sure that you get the competencies you need to be strong leaders, to support the model of care through the PHCs, through the whole continuum of care in the integrated health. So I'll just share with you a couple slides of how we did this. So this one is an example of the Damam Khatif Healthcare Network, where you have the chief executive officer who's in charge of his hospitals, very similar models for Damam and Khatif. So that's why I put it together. And then of course you have all the direct reports to the chief executive officer. But we made sure that we had the nursing executive director of nursing was on this highest level of the organizational chart, because, whoops, that's something here and I lost my slide. Because we wanted to make sure that nursing was represented at the highest level. The next slide, please. So in this slide, basically, we have, again, the example here is Khatif Health. You have your chief executive officer, who the executive nursing executive director reports directly to the chief executive officer. And if you look at this model, it's very lean. We try to keep it as simple as possible, because in the past models, we had deputies and associate directors. And I remember being a associate director at King Fahd Hospital, and I felt I was sandwiched between the executive director of nursing and the directors. So for me, and in talking to all the executive directors and the directors in the cluster, it was obvious that we wanted to have a lean structure where you had the nursing supervisors managed by a manager. In the future state, we are hoping that the case managers would be under the EDON. And then a very simple structure with an executive director, office manager, who would manage the staff who work in the nursing office. And then you directly have all your direct reports, which are, you know, depending on your organization and the services that are offered, you have your medical, surgical, OBGYN or whatever. So inpatient and outpatient representative. But more importantly, in the integrated health, we made sure that the PHC nursing director was also represented on this chart, because for collaboration, integration, and communication, this nursing director from the PHC needs to be in touch with all the other directors in the hospital to coordinate care. We found in the past, with the PHCs being in silos, it was kind of hard for them to operationalize their work. So having put them here, it really puts them directly in line with all the other directors to manage their patient care specifically, but also get the support from the hospital and the EDON to support any difficulties they're faced with, any pathways or workflow issues and so forth. And the last one I'll share is, before Janan goes into the PHC portion, is talking about the PHC MD lead here, but basically, if you look at the last arm there, you have the PHC nurse manager, where you have your nurses, care coordinators, health coaches, and patient care assistants supporting this model to support the operations in that clinic. And if you look at the last slide that we have now here, is basically saying each director of PHC that was in the hospital operational plan reporting directly to the executive director of nursing affairs. In our situation, it's Ms. Janan, who is the next speaker. And the reason was because there's a lot of work that's going on in the PHCs in terms of the model of care and operationalizing our patient pathways with the MOH plans, and trying to figure out how to marry those two programs and build maturity with the model of care in the future state. So if you look at the graph here, we basically have a nurse manager in the mega center with maybe 8 to 10 small clinics that will feed into the mega center, with the hope of patients going for higher services first to the mega center and then transferred to the secondary clinics if they needed a higher level of care. So in short, that's my presentation. I urge each chief nurse to make sure that you engage your staff, get them involved, and lead your teams for the success of the model of care and for the transformation. With that, I'll say thank you for listening, and if there are questions, I'll be glad to take them.
Thank you very much, Jessica, for your nice and informative presentation. If you have any question, please raise your hand or speak directly or write in the chat, so we'll be able to answer. During that time, there isn't a question raised by Ilham. Ilham, she said, what are the thoughts on aligning the nursing professionals' practice model with the model of care? Ilham, if you want to elaborate more on your questions or your comments.
Yeah, assalamu alaikum jami'an. Thank you, Jessica. This was very good, informative presentation. Thank you for sharing and the previous presentations. And it's great to see a lot of progress, mashallah.
Ilham, can you please tell us, introduce yourself, Ilham, first of all, so everyone knows. Thank you.
معكم إلهام العتيق, Dr. إلهام العتيق, W1 cluster, Chief of Nursing in W1 cluster in Mecca Healthcare. And previously I was in E1. It's nice to really hear this presentation and all this progress. My question is in terms of in the structure, the last structure, Jessica, I want to ask you about, I didn't see the quality and the education in the structure as director or manager. Yeah, go ahead.
So thank you for the question, and it's a pleasure to talk to you after so long.
Thank you.
Thank you. That slide, I purposely took off the nurse manager and the director, because what we were talking about while we created the job descriptions was we didn't want to dictate whether there was a director or a manager. We said, depending on the organization and the need, if it's going to be an accredited site and if they're going to have a lot of students, then definitely they would need, like a tertiary center would need a director. But a secondary hospital, and we're still, this is still in draft form, and still in conversations with Janan and so forth, because when you put the education for the PHCs and the model of care into the hospital setting, the burden becomes huge. And how do you manage that? And a lot of the work with the model of care now stays with the PHCs. So for that reason, I
Yes.
took those two off, because in some situations, we may have a nurse manager in the hospital and a nurse manager of professional development in the PHCs, and they will work together to make sure that there is communication and alignment. Now, if that organization is an accredited site, like the Mom Central, where they have are going to be accredited for trauma center and so forth, depending on the services that they will offer, which we've put in our job descriptions, that will dictate whether they need a director or a nurse manager. So we're
Yeah,
still in
thank you.
conversations about how we need to build this. We didn't want to rush into saying everyone should have a director, because then it
Yes.
becomes top heavy also. So I purposely took that off, because I didn't want to confuse people to say they have a director and so we should have a director. But I'll be glad to share our job descriptions and help you, to think about your design structure in your organizations.
Yeah, thank you so much, Jessica. Actually, this is a huge challenge, is like, looking at the shared governance based on the initiatives of any excellence nursing excellence or magnet standard, or like any standard of excellence in nursing. We have the shared governance, we have the model of professional nursing practice model that I know in King, yeah, you have it. So, how are you aligning all those within the MOC, to align the well-known excellence in nursing to have with the MOC? For example, the model, model of nursing practice, how is it aligned with the MOC?
So to be honest, we've had several conversations with the executive directors of nursing about this, because we have one hospital that has magnet and then the rest of them don't.
Yes.
But we know this is a very expensive proposition, trying to embark on magnet, and it's it takes a lot of time to get through that journey. Like in our situation here, it took us 8 years. I know at Duke it took us 12 years.
Yeah.
So this is not a simple proposition.
Absolutely,
but what we said
Jessica,
to the executive directors is that the principles of magnet are available to all of us. So we don't have to feel shy to adapt and to embrace. So one of the things we said to everyone, let's start to put in clinical practice units in all the hospitals, and get nurses to start brainstorming and empower them to problem solve and to creatively think at the front line. And so we're trying to embrace some of the principles and embed them without having magnet, but still having the safety and the clarity and the dimensions of magnet.
Yeah,
I don't know if
definitely.
that answers your question.
Yes. I wasn't talking about magnet. It's, you answered part of it that is true, that, adapting as any standard, like Sabahi, JCI, any standard that we based our improvement and nursing transformational, that is based on evidence-based in nursing research. My challenge was, how to really, we are in the exercise of creating the nursing professional practice model and align it with the MOC. So not necessarily having magnet or not, but just like to bring everybody, like the VRO brought everybody online with this model, MOC. So our challenge is how to do this alignment. And, I don't know if anybody can answer this.
يعطيك العافية دكتورة إلهام. How are you? I hope
دكتورة.
يعني الله يسلمك. It's always good to hear from you. Maybe I can just chip in and see whether I can try to answer your question.
That will be great.
So basically it's يعني communication is the answer. So if you're doing any sort of shared governance, or if you're doing a governance model for nursing, make sure there is a model of care representation. If there is model of care steering committee, there is always nursing representation. So we make sure and they're all aligned through every single activity that we do. So for instance, if we are, let's say, I think in model of care and nursing are not competing as much as they're complementing each other. So the absolute infrastructure is within the nursing and within the مثلا the physician affairs and so on and so forth, and the model of care is only there to kind of showcase some of the new models that can improve the way that we deliver our care going forward. So the way that we do it is, مثلا, we have a model of care steering committee. Jessica sits in that. We have weekly or twice a month meetings مع Jessica ومس جنان على أساس إنه we are involved mostly with regards to the primary healthcare, but also with regards to overall nursing affairs. We make sure that if there is training, that the training is all embedded with the new model of care structures. When they have any activities with regards to nursing, they always come back to us and say, is this aligned? Are we duplicating the work? Are we doing something that's a bit different, or is it aligned, and so on and so forth? So I think it's all a matter of communicating and finding what fits you. There is no one size that fits all. يعني you know yourself, مثلا in Mecca you have a very unique facility, infrastructure, geographic location. In you have, so it's very heavily populated, but it's يعني relatively speaking, if you compare it to E1, their E1 is spread over a bigger piece of area. So we have different rural areas. So socioeconomically as well, they're all different. So you have to then try to appeal in how can we manage something that's 600 kilometers away. So can we use virtual care? What are the basic core competencies that we require from nursing? And let's standardize it through virtual learning as opposed to physical learning. So this is where it comes in. I hope that answers part of your question.
Wallahi, well said, Dr. Mariam, well said. Thank you so much, congratulations for this great progress. Allah يوفقكم إن شاء الله. Thank you for sharing.
معاكم
الله
أجمعين.
يحفظكم إن شاء الله. Thank you.
Thank you very much, Dr. Ilham and Dr. Jessica and Dr. Mariam, for this nice conversation or questions. Any questions, Dr. Sami? موجود معنا عندك أي سؤال? Other nurses or representative from other clusters and non-clusters? Please don't hesitate to ask any questions, to have any comments. We are happy to answer and have a discussion with you. Okay. It seems there is no more questions. Noura, ما أدري عندك أي comments, أي questions for the guests?
No, thank you, Jessica.
Okay, so we'll move to the next agenda item, which is by Jinan, the role of the nursing leadership in supporting implementation of model of care and the PHCs. Jinan, yes, the mic is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good greeting for everybody. Very thankful to you and to model of care, actually model of care opportunity that help us to give the good picture for completing each other as a nursing and other multidisciplinary, especially with the doctors. So it was a great opportunity to us to show our power in nursing, how we can be the champion of change in this very important transformation in the kingdom.
Jinan, I'm so sorry to interrupt, بس صوتك شوي بعيد و it's cutting. لو تقربين.
Is it okay now?
A bit better.
Thank you very much, first of all, to join this very important session as a first nursing connection for clusters in the kingdom. And my reflect to that transformation in our healthcare delivery, especially in primary healthcare, really give us very good opportunity to show our power in nursing and complete each other with other multidisciplinary teams, especially doctors and others in the healthcare delivery system, that really we can do a lot to improve ourselves in this situation. First of all, I'd like to thank my teams, the art director of nursing, who helped me really to give very short and summarized information and knowledge about our journey in primary healthcare activity. Can you share me the screen, Hayat?
Sure, definitely. I will stop sharing this.
For me.
تفضلي.
Okay. But it seems the screen.
I thought you're gonna share the screen from your side. أنا already حاطته على ما أدري أنت ما كانوا طالع عندك.
لا مش طالع عندي.
اوكي sorry. لا هو already كنت فاتحت أنا. I shared it already, so okay, let me share it again. This is the screen. Can you see it now?
Yes.
Okay, good. Yes, go ahead.
First of all, thank you very much also for Dr. Jessica that really she gave very informative summarized our all activities during the journey of
صوتك بعيد جنان.
nutrition. Okay.
يروح ويجي صوتك. Yes.
So also thank you, Jessica, that she show us and show all of us the very important summarized activity in our journey, which is started by 2017 and up to date. And it was really a very hard work with that being played through all the team who's involved on the change process. Let's talk about leadership more because Jessica, she covers very excellent in the very operational part for nursing. But I'd like also to focus on the very important champions of change in our stage, who is the nursing leaders. And they were very passionate and they are very energized to help us and to make a real change in our healthcare services and to increase the patient satisfaction and patient safety, and also as well as the nursing satisfaction in doing their job. In nursing operation as a primary healthcare, we are committed to two important elements in doing our oral journey in model of care activities and other challenges that we have to make to succeed our change in healthcare services. First of all is to improve the safety for primary healthcare patients and supporting nursing staff through establishing safe patient nurse ratio, which is staffing. It was previously we weren't on a unique way that we were having different staffing in different area. For example, in Dammam, they were having different from Al Khobar and as well as for the rural area. So we establish a patient and nurse patient ratio, which help us to measure ourselves and assess ourselves according to the patient flow in each primary healthcare centers and to develop all the plans and improvement in our care and see our capability of improvement and implementation of the model of care activities in each zone. Also provide opportunities for nurses development and enhancement of primary healthcare nursing practice through different activities. One of very important is the nursing education, nurse education and training. And follow up also the assessment of primary healthcare nurses, directors and nurse managers, and with model of care, they all engaged in this journey. And we were really a very good teamwork that we involved from the front line to the managerial level nursing to the other multidisciplinary teams with the doctors. So really, it helped us a lot to come to the success step that we are now standing in our outcome. Also empowering nursing leadership roles to enhance their and share the implementation of model of care pathways. The pathways, the most priority and important pathways that we did in our these couples of years journey that we focus on care coordination, which is a chronic disease pathway component of hypertension, diabetes, and cardiometabolic disorder. Also the UCC activity, or I mean pathway, and safe birth and health coach. So we focus on these, and we have some KPIs. We measured ourselves, and we have we see the outcomes of that one, and help us to assess and re-evaluate our all steps. The second comment, the second thing that the nursing operation primary healthcare is committed to is participating in healthcare transformation journey of a new model of care through providing necessary support to all levels of model of care pathway, and to help people start from the nursing assistants, from nurses, staff nurses, nurse manager or head nurses in the clinic, to the supervisor, to all the people who is engaged in the journey. We were in everywhere with everybody to help them succeed application and implementation of the new model of pathway in our primary healthcare services, and conducting and providing integrated care. And طبعا الcare coordinator as a chronic disease pathway or model of care, really I would call it it did a change for our nurses' mind and way of thinking how to deliver their nursing care every day. Before they were delivering a very what is static, no soul of that one. But with the chronic disease model of care, really everybody to think again and use their capabilities and their qualifications and their experience to apply it in ideal and optimal way that will help to improve the satisfaction and give a safer practice in our primary healthcare systems. From that one also, it helped us to think to I don't know, this is not changing the screen, the slides. Through that one, we think that we need to do also something to help our practitioners to have a better output in their daily work. So 19, there were a reforming committee was launched in primary healthcare sectors, which included multidisciplinary team, doctors, pharmacists, nursing, and receptionists, IT. So in different with different multidisciplinary help us to reassess our facilities, either structure, resources, the manpower, to help us to succeed the implementation of model of care. So and to make sure that alignment of any change in the way of delivering the care will be aligned with the model of care implementation, and to review also our operational KPIs. Either we will increase it or we will swap it with other KPIs that will help us to assess our output. And the most important thing that helped us in this change or reforming committee, that implementation of the patient-nurse ratio for primary healthcare centers, and really to see our volume in each health center and what we can do, either to implement it or to extend our implementation of model of care in other primary healthcare centers, or to switch it to other one. Many activities also done as the model of care pathway. I will not repeat because Dr. Jessica and Dr. Mariam, she gave very well clarification what has done before for model of care, but I'd like to focus more. If you want to succeed your model of care implementation in
جينان، شكل الشبكة عندك مو مرة كويسة لأن صوتك يروح ويجي كثير. So
is it okay now?
يعني هو it's okay بس شوي بعدين يروح.
Yeah. Okay. I'd like to focus more in the key or the golden stone of succeed of model of care implementation is the training and training and learning opportunities to nurses, because model of care implementation, it is not focused only on nurses, it's multidisciplinary. It is physicians, nurses, and other people who is involving in delivering the care. So many workshops, many learning opportunities were done to orient our staff nurses, to qualify them, to help them and support them to do their work in appropriate and in a safe manner that align and integrated also with the extension of the care to the secondary also level in the hospital. طبعا for that, because we are believing my team primary care, we are believing in education, continuous education, instructional development of our staff nurses. It's very important to succeed any project in healthcare delivery is the training. So we did a proposal for primary healthcare nursing operation enhancement of nursing primary healthcare centers, and the vision and mission, we put our vision and mission on that one. At the end, to improve the quality of nursing care being delivered, either it is a primary, we want to have an excellency in our work in primary healthcare system. So we are now in the second phase of implementation. This is, we started now in Al Qatif sector with 28 primary healthcare centers. And we have our measuring tools to assess the performance and competencies for the nurses in their general competencies, and specifically in model of care such as UCC and chronic disease and the health coach. This is our objectives of the project: enhancement and empowering of nursing practice in primary healthcare settings. I don't know if you can hear me, still hear me good or...
صوتك والله لسه شوي يروح ويجي، ما أدري عندي أنا بس، ولا أتوقع الأغلبية يمكن الصوت يعني مكان شكل الشبكة اللي في أنت فيه مو كويسة.
Yeah, if you speak closer to the mic maybe يعني لأنه يروح ويجي زي ما قالت حياة.
طيب objectives of this project of our enhancement and empowering our nursing practice in primary healthcare centers is to have sustainable operational plan for internal refreshing and enhancement of nursing skills, as well as ensure maintenance and upgrading of staff competencies طبعا with zero errors in the practice. طبعا this is all aligned with the model of care needs and objectives, and achieve 100% of refreshing nursing training plans implementation that on the basic and important competencies, and support continuing professional education activities. We already mentioned previously in the slides the aim and the goal of the chronic care pathway, and help us a lot really in formulating our training activities for our nurses. This is the journey since 2017 and up to date, all in each part, or either with activities or with goals. Training of nurses was the most important arm and base to start to next step. So we upgrade the training according to the needs and according to the assessment in each time, in each phase that we pass through that one. And it helps us a lot really to assess our even resources and our, because we know that not only training is alone to help us to have the succeed, but also the other resources and the system itself help us a lot to succeed in outcome of nursing practice. For urgent care, I will just jump to the other slides. Through condensed training for urgent care pathway or urgent care model of care for our nurses, and all of that needs very qualified, competent nurses. So it was a lot of activities and a lot of training done to some groups of nurses. We did the training to them. We also, in coordination with the Dammam Central Hospital or Dammam Medical Complex, and also this for Dammam with Al Qatif, also with Qatif Central Hospital, and for Al Khubar with King Fahd University Hospital. They help us to prepare our staff nurses on UCC competencies. And through that one, we were able to open three UCC in primary healthcare centers. The most important that we vary in our learning approaches for our primary healthcare nurses, that it was on the theoretical part, and we have simulation lab that in coordination with King Fahd Specialist Hospital, and also one-to-one training and help us a lot to increase the number of UCC nursing with the good competent skills in running the UCC clinic. Plus that, طبعا, we gave them also triage courses, triaging with King Fahd Specialist Hospital, and also the Dammam Medical Complex Hospital. So it is integration because it is integrated health zone and primary healthcare centers with the hospitals. We seek all and utilize the benefit of being in one umbrella with professional development department in each hospital. Help us a lot to improve and qualify our nurses to work in this new pathway in primary healthcare centers. طبعا there is also another pathways that we are running and planning. In implementation phase with the maternity care and also pediatric care. In maternity care, there is an Al Qadsiya specialized clinic. This for low and mid-risk pregnant ladies. With this clinic run with the specialist, OB/GYN specialist, and obstetric. And with a midwife, nurse midwife, with trained training offered to them how to do the pathway in its proper way. For pediatric, let me just to show some challenges that we faced during the pandemic and the nurses how they did well in that one. As you know, in the pandemic, many primary healthcare centers were closed, and either because of curfew or because of minimizing the number of manpower of nurses and use them in other support other facilities such as quarantines, hospitals, field screening, and the community hospitals. So there were a dramatic increase in unvaccinated children for under 5 vaccinations, which is very dangerous and alarming. High risk that we will have a very big number with children not vaccinated. So the immediate action we did groups with nurses, and they started to contact the families and the patient, or the children, their families, and give them the very important education about vaccination and schedule them to come, and with the special pathway not to expose them to any contamination with COVID-19. So all of that done with the nurses' effort and plus their leadership and their directors. Pandemic, it was a very, very important time that it helped us to see our capabilities, our power in doing our job in primary healthcare centers. So the nurses they try to overcome all the obstacles that they are facing during their daily primary healthcare work for their communities or their patients. So they were, in spite of having shortage in our number of manpower or nursing, in spite of having unhealthy nurses because of either they are in contamination or they are high risk to be exposed to contamination, the nursing leadership really they did a very good job in the scheduling and the planning to cover all the healthcare activities without jeopardizing the patient safety to their communities. So this is some points regarding all the activities done. Through the director of nursing try to also monitor what is the actual situation. And the last slide of this one, director of nursing and their managers and their staff nurses, they have a very big responsibility to help succeed of all the model of care activities through their positive and mindful of all the situation of our staff nurses in primary healthcare centers, and engaging all the level of nurses, either they are health assistant nurses, to let them engage in the planning for future transformation or positive change that we want to do it in our primary healthcare centers. Also with continuous motivation to our nurses that help us to have a very good or a high satisfaction to our nurses, which will reflect the high satisfaction to our patient. So this is the end of the slide. I don't know if you were hearing me clearly, but if you have any question, I'm very happy to hear from you.
Thank you, Jinan, for your presentation. Thank you very much. If you have, please, any question, please raise it.
I have a question. I just want to hear, okay, Dr. Manal maybe first and then myself.
تفضل. دكتورة منال تفضلي. دكتورة منال. دكتورة منال. شكلي يمكن ما أعرف رفع يدها. دكتورة دكتورة منال تفضلي.
Yes, thank you, Dr. Jinan, for this valuable presentation and for all the speakers. Really, it's informative. My question is during implementation, if we have like a case coordination for the chronic disease pathway. Sometimes if we train the case coordinator to train the team, they have already task before. They are working as this and this. He has a specific role. So how can we give a solution for this case? If he has a role and he also he has a task for training the others. What is your opinion?
اهلا دكتوره، عفوا دكتوره منال ولا مين معي؟
دكتورة منال يس موديل الليدز يس في الشمال. هايل تفضلي.
يا هلا فيك.
هلا بك. يس جينان. جنان صوتك يس سنان ما زال صوتك يروح ويجي. جنان صوتك لا ما نسمعه ما نسمع أبد.
It's very important.
جنان
Can you hear me now?
لا يقطع صراحة صوتك. ممكن أتوقع المكان اللي أنت فيه ممكن تغيرين شوي.
أيوة can hear. ممكن دكتورة جيسيكا answer because we are in the same line, in the same page if she is available.
I think she left because she has another commitment.
Meeting, yeah.
Yeah. This you can answer, Jinan.
Okay. طبعا هو organized training should be organized training. Hello.
Yes, Jinan تفضلي.
Yeah. The training يعني everybody you feel that he has to be involved, you have to involve him and regardless his role, either she is in managerial level or training or staff nurse. احنا our experience, we used our nursing supervisor for a chronic disease. We engage the nurses the primary care who as a chronic disease nurse and the head nurse and primary health care centers. So we join them in groups every طبعا can 3 to 4 groups in each year that help us to spread the idea of model of care and طبعا follow up because we engage the manager, the director of nursing, plus the nursing supervisor for model of care for chronic disease. Nurse help us a lot to follow up the training and implementation of the concept of model of care for a chronic disease. طبعا with continuous meetings every day we were in contact with them. Twice a weekly we were in their health centers to assess their implementation. فالعملية حتكون عملية مجدولة وطبعا every time you engage the people with their directors and their supervisors to help you to succeed in this step. I hope you can hear me.
Yeah, thank you, Dr. Jinan, for clarification. Yes, thank you.
Thank you. دكتورة مريم تفضل.
Yeah, and I think as well in Dr. Manal, very important question. I think it's just that احنا عادة if your question has to do with they're also busy with normal activities and how can we schedule this on top of everything else that they're doing and so on and so forth. I believe يعني nursing are the best in scheduling, rostering, sorting out the time to make sure that everything is sorted. As long as it becomes part of their job description, or they are given dedicated time, or their rosters are done in a way that these things are scheduled مثل ما قالت Ms. Jinan, and it's scheduled as an actual activity, they will be able to cross cover each other. I think أنا دائما أقول يعني I just leave it to nursing. أقول لهم this is probably what we need. Let us know if that fits you. Then you design it the way that you feel is right. Protecting time, scheduling it, doing TOT, how much time do they need off, they know how to manage it themselves. Maybe that's part of the answer of the question.
Yeah, thank you, Dr. Mariam.
Thank you, Dr. Mariam. Any more question?
Anna, I have a question that I just want to ask, yani, just openly, honestly, how many of you are, and again, this is not to point fingers or anything, how many of you are very much heavily involved مع model of care teams? Even by raising your hand or mentioning something.
Can we go one by one نسألهم؟ إيش رأيك دكتورة مريم؟ خلينا شوي يصحصحون.
يعني على اوكي على راحتكم
يصحصحون.
I'm just interested يعني ايه.
طيب عبد الله الدهام أو دمان ما أدري معنى الدامن. أستاذ عبد الله. أحلام اليوسف، بسمة، دعاء الزير، إلهام of course يعني she's involved يعني heavily، فهد خالدي. So please ask يعني answer question of Dr. Mariam, how heavily you are engaged in model of care activities within your clusters or within your regions. حورة، منار، رويلي، قريشة and روعة، Reem. We need to hear your voice, ladies and gentlemen. تفضلوا.
No. Hi everybody. Rawi Idris is speaking.
Yes,
I would like to answer the question for Dr. Mariam.
راوي عرفي بنفسك عشان بس تكون يعني live experience للأذرز تكون إن شاء الله positive to them. عرفي بنفسك راوية.
Yeah, my name is Rawi Idris. I am the ON of Al Kubar Primary Healthcare Centers. I have 13 years experience in primary healthcare, plus the other experience in DMC. My qualification is Master of Nursing Leadership and Education. Actually, I graduated since 1 year from the UK. My answer to Dr. Mariam, that me as a nursing director, I'm highly engaged with the model of care with E1 cluster. Actually, I attend a lot of workshops with the E1 cluster, and also the project manager in our sector. We are working as a team with her. So for me, actually, I am highly involved.
Beautiful, Rawia. Beautiful. Thank you.
Welcome.
Thank you. Anyone would like to answer the question? And please feel free to participate and have your thoughts. Yeah.
دكتور صالح، في عندنا ريم.
Yes.
ريم باشهاب.
Yes.
تفضل.
حياك الله دكتورة.
أيوة.
Yes, can you please tell us your experience or your يعني how heavily you are engaged in model of care within your cluster?
Yes, I'm Reem Bashab from Mecca. We are now on process on model of care with W1 cluster. I'm invited by Dr. Ilham. Thank you, Dr. Ilham. And we started on process. I take a very nice experience by this meeting. Thank you. I'm looking forward to be like you in E1 cluster, inshallah. And yes, we were involved in model of care now.
Fantastic. Dr. Saleh?
حياك الله دكتورة. صالح الدهيمان، نائب الرئيس التنفيذي لخدمات التمريض في التجمع الثاني في الشرقية A2. احنا للأسف not engaged مع الموديل اوف كير الآن، لكن أعتقد إنه خلال الفترة الجاية يمكن الأسبوعين الجايات حنبدأ إن شاء الله نشتغل معاهم في الموضوع.
Absolutely, absolutely. يعني I think Dr. Saleh ترى everybody is in that boat probably. So يعني we totally agree with you. Dr. Saleh is involved في the coronary strategy, في the cardiac strategy. So he's been involved with transformation, obviously, very much. So it will be easy for you to do model of care very easily. Because I think it is important يعني in the nursing leads or vice presidents or chiefs كلهم they get يعني I think in sometimes the model of care they're in their own little world, so I think it will be upon yourselves to go there and say let's work together. يمكن it has to be more proactive from your side, and this was very obvious from our own Eastern Hub CNO Connect. حتى Grusha is now more involved. صح Grusha? من ال E3. I think she left me.
Yeah.
Okay.
So we still remain 5 minutes more to finish this connection. I think Dr. Ilham raised her hand. Dr. Ilham, تفضلي.
Yeah. Actually, you know, in W1, they're still in early stages, but the good thing that nursing is really involved in all the rollout working group from the beginning. So we have representatives from the hospital, from PHCs, which we're doing the learning together, and which is really great. Thank you, Dr. Mariam. Honestly, you know, we can make transformational more effective if we really understand the model of care and the pathway and align our efforts together. But thank you. This was really very nice. Thank you so much.
يعطيك العافية دكتورة.
الله يحفظكم.
Thank you. Any more questions, thoughts, comments from the rest of the participants? Dr. Sami, عندك أي تعليق أو أي thoughts with regarding the role of nursing?
السلام عليكم. ما أعرف لو أقدر بس
تفضلي يا بسمة.
إضافة بسيطة.
Sure, definitely. تفضلي بسمة.
الله يعطيك العافية. First of all, thanks for all the presentation and sharing the experience. Actually, what has been done so far in Eastern region, it's really an amazing work. Actually, I'm here on behalf of Mrs. Iman Badokhun for Jeddah administration. We're not yet involved maybe in the clusters, but we are still working with the transformation office here in Jeddah. So regarding the model of care, we're in the middle of a project where we are trying to preparing, if I can say, not actually nurses. What we came up with is not nurses only, it's more than nurses. So actually, maybe it's a question and something maybe to just put on a table, maybe for later or future meeting like this. Do we have really nurses supposed to be working in a care coordinator position, or this position could be covered by other specialty? And this is what we are trying to do here in Jeddah. We started to establish the care coordinator, but we did not just limit the nurses to be in this position. We started to work with even other specialty since they have certain criteria like the language, the background, and you know the needed information or knowledge that they need. Thank you so much.
Thank you, Basma. If I may, Hayat, because I know now we have
تفضلي
like a
تفضل
minute. Yeah,
تفضل
there's a
تفضلي
problem.
دكتور.
So excellent question. And just let me tell you very briefly, in care coordination is a new job. And it's getting accredited by هيئة التخصصات الصحية. And the inclusion criteria is not limited to nursing. But nursing is the obvious favorite, but it's not limited to nursing. It is... it also includes, you can have like allied health, you can have other people that can do it. The minimum criteria has to be met, and they have to have had at least 1 year of working as a healthcare provider, and they should have a minimum of, I think, diploma at the moment. لأن initially they said you need to have a BSc. And we said لا يعني for care coordination you can even use the nurses that have a diploma degree, so SN2 I think is what they're called, along with other allied health professionals. So if you have somebody who was doing like مثلا physical therapy and now for whatever reason they cannot work in physical therapy department, they can become healthcare providers, or the pharmacy technicians that now are no longer in need because we have WASFATI, they can work as care coordinators. So, so there is a minimum criteria, and they just enter that training, and then they graduate from it. With nursing, the degree of training that you need is much less than other allied health. That's definitely something to consider, yes. Thank you.
Thank you, Dr. Mariam. Any more questions? Thoughts? Okay. Thank you very much for this presentation, for your meetings altogether and your participation in this. And hopefully that you're gonna enjoy the meeting. And inshallah, in future, we're gonna have more monthly meeting on this. Thank you very much and see you again, inshallah, next month. Thank you.